Welcome to the Deep Dive. We're here to cut through the complex source material and give you the core knowledge you really need. Today, we are taking a close look at the 2025 CPT surgery guidelines. If you deal with surgical reporting or procedure evaluation, compliance, well, this deep dive is basically your essential map. Okay, let's unpack this. Our goal here is pretty straightforward. Give you a clear roadmap for reporting surgical procedures and services generally. We really need to focus on what's bundled into the surgery's cost. That's the CPT surgical package. And critically, what the guidelines say you can report separately.
Exactly. And getting that clarity isn't just nice to have. It's really the financial foundation for any surgical practice. These guidelines, they basically define the economic unit of surgery. If you don't know precisely what work is included in that base payment, you risk underbilling, leaving money on the table, or overbilling, which, triggers audits. Understanding the structure is really key to cutting down the noise and making sure payment actually reflects the work done in 2025.
Okay, let's start right there. With that foundation, the CPT surgical package, this is the definition, right?
Yep.
The services that are just inherently part of the surgery's value. So not separately reported. And this bucket, it seems surprisingly big. What are the absolute core components we need to have memorized?
Yeah, there are 7 key components making up this package. If you can really define the edges of these 7, you're halfway there in managing audit risk. First, obviously, is the main event, the operation itself.
Right.
Second, the basic pain management right at the site. So local infiltration, maybe a metacarpal, metatarsal, or digital blog, or just topical anesthesia.
Okay.
Third, and this one trips people up sometimes, it includes one related EM service. That's your history and physical exam. But the key is when it happens, on the day immediately before the procedure, or on the actual day of the procedure.
Wait, hang on. I need to pause you right there on number 3. That one related EM service, that's really specific. It makes it clear that the pre-op H&P, the one that really checks if the patient's ready for surgery, that's usually bundled in, even if it's the day before. So does that mean, say the patient came in a week earlier for just routine scheduling stuff, that initial visit could potentially be billed separately because it's outside that immediate window?
Precisely. That's exactly right. The guidelines are very clear about the timing, the day before or the day of. Any EM service before that time frame, assuming, it's properly documented and medically necessary, it falls outside that bundled package. The rule is really meant to cover that final check, the confirmation of fitness for surgery, not the whole diagnostic journey leading up to it.
Okay, wow. That's a huge clarification, especially for poders. What about the rest of the package? What else do we need to account for?
All right, continuing the list. Now we move into what happens right after the surgery, still in the facility. Fourth is the immediate post-operative care. This includes stuff people don't always think about, like dictating the op notes and, importantly, talking with the patient's family. Fifth, writing orders. That's both pre-op and post-op instructions for the staff at the facility.
Got it.
Sixth, that really crucial step, evaluating the patient in the recovery room, making sure they're stable before they get moved or discharged. And finally, number 7 is the typical post-operative follow-up care. This covers all that routine stuff, standard office visits during the global period, routine wound checks, taking out sutures or staples, things like that.
Okay, that 7th one, typical post-op follow-up care, that feels like where the rubber really meets the road. For our audience, the immediate question is, what counts as typical? And how long does this follow-up period last? Is it 10 days, 90 days? How do coders actually know the limit there?
That is the million-dollar question, isn't it? The length, what we call the global period, is actually set by the procedure's specific CPT code. CPT assigns a global period. Usually it's 0, 10, or 90 days based on how complex the procedure is. So if a procedure has, say, a 90-day global period, all those routine follow-up services for that specific surgical issue, wound checks, suture removal, they're all bundled for those 90 days. Knowing the global period for your primary CPT code is, well, it's absolutely non-negotiable.
Right, and like the source material mentioned with that MJ Gem analogy, it's basically all the work that comes with surgery. But, and this is the big but, the bundle specifically doesn't include complications or managing unrelated conditions long-term or services that just aren't usually part of it. Those exclusions, that's the compliance challenge, isn't it? And probably where auditors focus.
Exactly. And, the rules for follow-up care also depend quite a bit on whether the original procedure was diagnostic or therapeutic. For diagnostic procedures, think biopsies. If the follow-up is really integral to understanding the result, it's included. The classic example the guidelines use is discussing biopsy results. That conversation itself is considered part of the diagnostic procedure package. You can't bill it separately, even if it's during a later office visit.
Okay, that seems pretty clear for diagnostics.
Yeah.
Getting the answer is part of the test. But for therapeutic surgery, the actual fix or removal, we know the typical post-op care is bundled. But here's where, like you said, it gets really interesting. What if things go wrong? Complications.
Yes, this is where we see some major reporting differences for 2025. Minor issues, things managed easily in the office, like maybe adjusting a dressing or treating a very superficial infection, those are generally still part of the global package. But the rule shifts significantly if the complication gets more serious. If that complication means the patient has to have a return trip to the operating room or, an equivalent place like an endoscopy suite, the procedure represents a major unexpected use of resources. It's seen as a separate event, and those procedures may be separately reported, but you have to use the right CPT modifiers, like modifier -78 or -79, depending on exactly why they went back.
Okay, that distinction, minor issue in the office versus a complication needing another OR trip, that seems like the critical line separating bundled work from separately billable work. But hold on, wasn't this specific point, the office versus OR management, kind of a gray area for years, especially for minor things, needing maybe just some sedation in the office? Is the 2025 language clearer on that specific dividing line?
It is clearer. The emphasis on the operating room or an equivalent facility is the main clarification. It's the complexity, the use of those facility resources, needing monitored anesthesia, sterility. Those are the factors that justify unbundling it. The 2025 guidelines really stress that the venue reflects the severity. It separates that routine post-op recovery, which is bundled, from the unexpected second intervention, which isn't. This helps a lot in audit defense because it gives you a more objective trigger point.
That's huge. That venue difference completely changes the financial picture. Speaking of finances, we've talked about the work involved in managing complications. Let's pivot to the cost of the materials used and then maybe touch on how to report multiple procedures done at the same time.
Good transition. For supplied materials, the basic rule is straightforward. Routine stuff like dressing, standard sutures, supplies used during the actual procedure, those are always included in the surgical package. Think of it as overhead. However, if the surgeon provides materials that go beyond the usual and the guidelines specifically mention things like casts, splints, or even certain braces, durable medical equipment, those can be reported separately. But, and this is key, you absolutely cannot use regular CPT codes for these items. You must use the specific HCPCS Level 2 codes.
Okay. So the CPT code covers the surgeon's work, their skill and time, while the HCPCS Level 2 code captures the cost of the actual physical item given to the patient. It's a way to make sure those extra materials get valued correctly without messing up the value of the procedure code itself.
Precisely. CPT is for the clinical service. HCPCS Level 2 is for the goods and supplies. Now, let's tackle reporting multiple procedures in one session. This is definitely a compliance hotspot, right? So when a patient has several procedures during the same operation, you do list each CPT code. But how payment works and how you report it clearly really depends on modifiers. You list the most complex or major procedure first, that's the primary service. Then any lesser procedure done in that same session, through the same incision usually, needs modifier NAG 51 added. That signals multiple procedures.
That modifier NAG 51, that's key for the reimbursement hierarchy, right?
Right.
Because the payer usually pays, 100% for the main one and then maybe 50% for the second one. But doesn't that system create a pretty high audit risk, figuring out which procedure is truly primary or most complex?
It definitely can. The audit risk comes from a couple of places. First, getting the order wrong, listing the lesser procedure first, and second, applying modifier NAGS 51 incorrectly, like putting it on codes that are exempt. Certain add-on codes, for instance. You really have to look at the relative value units, RVUs, or whatever method the payer uses to figure out the true primary service before you add that modifier. It ensures you're not, accidentally overstating the total effort.
Okay.
This also connects to those codes marked separate procedure. This label causes a lot of confusion. These codes describe procedures that are usually just component parts of a bigger service. They automatically get bundled in when done with that larger procedure. They're only reported separately in two specific situations. One, if they are the only thing done for the patient in that encounter. Or two, if they're performed at a totally separate site or incision and are genuinely unrelated to the main surgery that was performed.
Okay, so that separate procedure tag is basically like a safety valve. It makes sure if that minor thing is the only reason the patient is there, it gets coded. Otherwise, it just kind of folds back into the value of the main service it was done with.
Exactly. It stops unbundling, but still allows that isolated service to be paid for when it stands alone.
Right. Finally, we need to talk about the safety net for when things are new or different. Innovation happens, right? Surgeons develop new techniques, or sometimes they do a procedure that just doesn't have its own CPT code yet. That must create complexity.
Absolutely. And in CPT, you can't just pick the closest code. Approximation isn't allowed. If a service or procedure is done and there's no specific code for it, you must use an unlisted procedure code. You
Right.
can't try to force fit it into an existing related code, even if it seems similar.
Unlisted code. Okay.
But using an unlisted code, well, that triggers the highest level of documentation scrutiny because the payer has no set benchmark for what it's worth. Your documentation has to clearly explain three things: what exactly was done, why it was medically necessary, and this is crucial how it compares in both complexity and time to other established procedures that do have CPT codes.
Whoa, that comparison requirement.
Yeah.
That's fascinating. You're essentially asking the surgeon or the coder to basically write the justification for the payment level. Comparing the new thing to the old framework based on time and complexity, that sounds like a massive burden of proof. Can you imagine trying to describe some cutting-edge robotic technique by comparing its time and complexity to, like, a standard open surgery from 30 years ago?
That is precisely the challenge. The documentation burden is significant because that comparison is really the only way the payer can assign a value they see as justifiable. They're trying to fit the new procedure into their existing payment models, trying to ensure some kind of fairness based on resource use compared to defined procedures. It's an administrative pressure that helps keep the CPT system structured even while surgical techniques are rapidly evolving.
Right, it keeps things grounded in the existing system.
So if we boil down these essential 2025 guidelines, you've got to master the definitions typical, related, routine to know what's in those 7 bundled services in the surgical package. You need to understand that specific trigger, the return to the OR, that unbundles complication management.
Mhm.
And finally, using modifier NANA 51 correctly and using the right HCPCS level 2 codes for those extra materials, those are just non-negotiable for compliance.
So what does this all mean for you, the listener? It means that compliant reporting in 2025 really hinges on mastering these boundaries we've discussed. That day before EM limit, the OR venue requirement for complications, and that comparative documentation needed for new procedures. Getting those right is key.
And maybe connecting this to the bigger picture, here's something to think about. How will that requirement, the one forcing comparison of unlisted procedures to existing codes, how might that shape clinical innovation going forward? Does forcing these new, often complex technologies to justify themselves against older definitions of surgical time and effort maybe create a kind of ceiling on how fast surgical value can be recognized and evolve? Consider the pressure that puts on the documentation itself, forcing every new approach to argue its worth against the past. Definitely something for you to mull over as you integrate these 2025 guidelines.